It is April 16th, Wednesday, House Healthcare, and we're continuing our discussions on S-126. We're kind of pivoting right now between sections 2 and 3 and kind of moving also into 4, 5, and 6. And so we're going to take some testimony on 2 and 3 today, although if anyone wants to throw in additional information regarding hospital budgeting, which is 4, 5, 6, then we're more than happy to hear your expert testimony. So we have with us Christopher Whaley.
Hi, can you hear me?
We can. Good
Great.
morning.
Hi, thank you for having me. And I sent around a pair of slides earlier. I can share them if that works well. Uh,
Yeah, that would be great. Thank you.
great, great. And then can you also just remind me about how much time I have? And because I don't want to go over.
Um, Half hour or
Perfect.
more. You know what?
Hopefully
Take the
be
time.
well under that.
Take the time that you need.
Great. So I've well under half hour, but happy to answer questions because I understand there's lots of discussion around this topic and especially related to hospital prices. By way of introduction, I'm an associate professor at Brown University as well as a healthcare economist. I used to be at the RAND Corporation where I led a large study where we actually looked at hospital prices across the country using many different data sources, including within the state of Vermont, the Vermont All-Payer Claims Database. And so some of the work that I'm going to highlight today is result of that study, where we've actually been able to do a pretty deep dive and look at how hospital prices in Vermont compare both within the state as well as across the country. And so just to kind of set the stage and why I think this is an important issue, is that if we go back over the last 2 decades, what we really see is what I think is a concerning trend, that we're essentially paying for worker pay increases in the form of healthcare dollars rather than take-home dollars. And so if we look at where healthcare costs have been financed over the last 2 decades, we see that there's been a huge explosion in deductibles. This is the time that there's been a large rise in high deductible healthcare plans, which place an enormous financial burden on patients. There's also been a huge increase in premiums. It now costs around $25,000 to provide health insurance for a family. And if we look at where that money has come from, it's come directly out of worker wages. And so over the last 2 decades, worker take-home pay has barely kept pace with inflation and has been almost the exact same rate of growth over the last 2 decades. And so this is a concern, and I think really drives why there's many policy efforts to address rising healthcare costs, because again, it comes directly out of worker wages and what we can take home as take-home pay. And it's important to look at where that spending growth has actually come from. If we look at utilization or even use of new and advanced services, there actually hasn't been that much growth. But where we see really the large increase in spending is driven by prices, and particularly for hospital care. And so if we look across the entire economy, we see that the area with the largest growth in expenses, or price growth rather, has been for hospital care, where prices have increased more than 200% since 2000. This is well above the overall inflation rate of about 75%. And if we look at other high technology services, whether it's computer software, cell phones, prices have actually come down in inflation adjusted terms. And before we put too much of the onus on hospitals, if we look at college tuition, the industry that I work in, we're second, and I think a lot of the same structural issues that have impacted tuition costs are also important for hospital prices. And so in light of that, there's been many policy proposals to essentially have several ways of tying commercial prices to Medicare prices. And I think this has led to a lot of important discussion on how do we actually create these ties, or how do we link what's paid on the commercial side to what's paid on the Medicare side. And I just want to take a step back and actually look at what Medicare prices are. And so if we look at what tying a commercial price to a percent of Medicare, and so a common way to do this would be to say we're going to limit prices to say 200 or 250 or 300% of what Medicare pays. I think one really important thing to keep in mind is that these percent of Medicare prices are a price benchmark and not a price endpoint. And so I don't think any policymakers want to say that commercial payers should pay exactly what Medicare pays without changes to the Medicare system. That's a pretty large change. But the advantage of using percent of Medicare as a price benchmark is that it's a relatively easy way to compare hospital prices. And so if you see that one hospital is, say, priced at 200% of Medicare and another hospital is priced at 300% of Medicare, then that's a pretty easy way to compare which hospital is more expensive. The other advantage of percent of Medicare is it's in addition to be a easy way to benchmark prices to the largest purchaser of healthcare services in the world, it's something that is pretty transparent and empirically based. So Medicare has a common methodology for setting prices, and we collectively can see what those prices are. They're available publicly and available online, so anyone can go see what Medicare prices for a given service are. And there's something that are also developed with lots of thought and stakeholder input, including from the delivery system. And then I think the other advantage of using Medicare is that they're roughly the break-even point. And so the Medicare Payment Advisor Commission, or MedPAC, states and also finds that Medicare rates are pretty close to break even, and they're actually designed for efficient hospitals to be break even plus a 1% margin. And so it is about the rate that a hospital can reasonably cover its costs. And we see that in our data as well, where many hospitals have pretty substantial operating margins on Medicare costs.
I think we have a question.
Yeah,
Okay.
Thank you for this. I'm wondering if you measured quality so that when you looked at more efficient hospitals, could you compare quality to others?
That's a really great question. I will touch on that in about 3 or 4 slides.
Thank you.
And so I mentioned earlier that we've, when I was at RAND, done several studies where we looked at hospital prices. And so for this study, we collected data from many self-funded employer healthcare plans, as well as data from many state all-payer claims databases. And with this the study, we're able to look at hospital prices across the country and actually, unique to this study, name individual hospitals and say how one hospital price compares to the other hospital. For this study, we looked at prices in 2 ways. The most common way, and what I presented here, is the percent of Medicare. And so this is for a commercial insurer. How much are they paying relative to what Medicare would pay for the exact same service at the exact same provider on the exact same day. The percent of Medicare benchmark that we include includes differential payments to, say, critical access hospitals, which have a unique payment under a model under the Medicare system, as well as some of the unique payments that are particularly added towards teaching hospitals to provide costs for doing that teaching and training future physicians. We've also added in to our Medicare prices payments that Medicare makes to what's called disproportionate share hospitals. And these are hospitals that have a large volume of uninsured or Medicaid patients. Now, some purchasers may say, look, it's great that Medicare adds in those prices or those additional payments, but we just want to have a single dollar amount. And for that, we've also done what we call a standardized price that essentially strips out all those additional Medicare payments and just has more of a dollars to dollars comparison. But if we use our percent of Medicare comparison, what we see is that nationally, commercial insurers are paying about 250% of what Medicare pays. And so what that means is that commercial insurers are paying what Medicare pays, plus an additional 150% on top of that. So again, keep in mind that Medicare rates are designed, and we actually see roughly the break-even rate for an efficient hospital. And that's so the additional 150% on top of that is, at least in my view, a relatively healthy margin that hospitals are getting from commercial insurers. The other thing that's really surprising is just the wide degree of variation in hospital prices. And so we see on the lower end, some states like Arkansas, Mississippi, and Michigan have hospital prices that for commercial insurers are less than 200% Medicare. While on the upper end, states like South Carolina, West Virginia, and Florida have prices that are well above 300% of Medicare. Keep in mind that this is almost a $1 trillion industry, and it's hard to think about a similar size and similarly important industry that has this degree of price variation.
We have a question. Oh, I guess
Okay.
not. I was actually wondering though, is this aggregate of all the hospitals, or are I guess is it basically just an average of all 14 hospitals and they roughly come out to 250, or is this for all the claims that are paid, it equals out to about 250?
This is the across all 14 hospitals in Vermont, but accounting for the differences in volume. And so hospitals that have a larger share volume will disproportionately account for the overall Vermont average, which is about 275% Medicare.
Okay,
and I'll
great.
highlight that difference in the next slide.
Okay, great. Thank you. Sorry.
And so nationally, we see that Vermont is a little bit above the national average and higher than its New England counterparts. And so, as I just mentioned, that's the across Vermont look, but we look within Vermont, we see almost the same scale of variation that we see nationally. And so we have some hospitals, Copley, Springfield, and Porter Hospital, that are around 150% of Medicare. And we have other hospitals, such as Southwestern Vermont Medical Center and the University of Vermont, that are around 300% of Medicare. And so just across Vermont hospitals, there's almost a 2x variation in hospital prices. I think a unique thing about the Vermont market is just the number of critical access hospitals, which I've highlighted in the light shaded colors here. And they have a unique payment model under Medicare where Medicare essentially pays at cost. And so a percent of Medicare cost between a critical access hospital and a non-critical access hospital is a little bit of an apples to oranges comparison, just because the payment model is a little bit different. But the main takeaway is that regardless of the hospital type, there's a huge amount of variation in hospital prices for Vermont hospitals. And so I think it's important to take a step back and look at what actually contributes to this price variation. And so there's really, I think, three main arguments that really come up on why there is such degrees of price variation. The first is the commonly referred to the cost shifting argument. And that argument is that a hospital with a high share of either Medicare, Medicaid, or uncompensated or charity care patients has to charge higher prices to commercial patients to offset that. As I'll highlight in a minute, we don't really find much support of that argument, and cost shifting doesn't seem to drive variation prices. Another argument is that hospitals with high prices just have better quality, and so you get what you pay for. And as I'll show in a few minutes, we also don't find much evidence of that. But where we do find a pretty strong relationship is with market power, and hospitals that have a larger bargaining presence with commercial insurers and are a must-have hospital with commercial insurers tend to have higher prices. And that's consistent with what we find both nationally as well as in Vermont. And so, as I mentioned earlier, if we look at cost shifting, we don't really find a lot of support for that argument. And so just to highlight that, what I've plotted here is on the bottom axis, the share of each hospital's patient volume that comes from somewhere else besides private insurers. And so this includes Medicare patients, Medicaid patients, uninsured, and charity care patients. And on the y-axis, I plotted the hospital's commercial insurance price relative to what Medicare pays. And just to distinguish, I've plotted both in the triangles in the darker colors, the critical access hospitals, and in the light shaded circles, the non-critical access hospitals. And so if the argument that hospitals that have a larger share of non-private patients should get higher prices, then we should see a roughly increasing trend line throughout this plot. But instead, what we see is, basically a random collections of dots, and if we do statistical tests, there's no relationship between a hospital's share of non-private patients and their commercial price. And instead, it's not really the cost shifting argument that drives hospital prices. It's being a must-have hospital for commercial insurers, which in many cases actually includes not having many uninsured or Medicaid patients in the building. If we look at quality, we also don't find a very strong relationship. And so what I've done here is take the 14 or so hospitals in Vermont and plot their price, but bucket them according to quality metrics using the Medicare quality star ratings. And so this is, just like the Yelp reviews, where a 1-star hospital is the lowest and 5-star hospitals are the highest quality. Fortunately, Vermont, it looks like doesn't have any 1-star hospitals, but does have a range of 2, 3, 4, and 5-star hospitals. And so I think the important takeaway here is that within each quality bucket, we see many hospitals that are higher priced and approaching 300% of Medicare. And we also see many hospitals that are much lower priced. And so each of the 2, 3, 4, and 5-star hospitals, or quality score groupings rather, has a hospital that is around 200% of Medicare. And so if we take this data, there's really not a strong link between hospital price and quality within the state of Vermont. And if we do this nationally, we find a very, very similar story. And so what does drive variation in hospital prices? So if we look instead of at price or quality or cost shifting, instead look at a hospital's market share. And so here we use the size of the hospital to define market share, and look at the relationship between hospital market share and hospital prices. We do find a really strong relationship where hospitals that do have a stronger market presence are able to negotiate higher prices and are able to command higher prices. And we see that reflected in the data. And again, this is true for Vermont, and it's also true if we do this nationally. And so what could be done about this? So I think one of the current policy solutions on the table is reference-based pricing. Reference-based pricing has a pretty long history within public purchasers. The state of California pioneered reference-based pricing about a decade ago to deal with some of the fiscal constraints that the state employee health plan was facing. And there, what they recognized is similar to the variation in hospital prices, there's also a large difference in site of care. So, for example, if you were to get your, say, colonoscopy or MRI in a freestanding ambulatory surgical center versus a hospital outpatient department, the price in many cases is almost double. And so or CalPERS rather, implemented reference-based pricing as a way to shift patients from high-priced hospitals to lower-priced non-hospital sites of care. And what they found was a pretty large difference. And so here, what I've plotted is just the share of patients who go to a non-hospital setting, started with following the implementation of reference-based pricing between CalPERS and a comparison group of Anthem insured enrollees. We're doing several evaluations. What we found is that across the services that CalPERS applied reference-based pricing to, they've achieved about a 20% saving on these services, and actually seen quality improvements because the providers that are outside the hospital actually tend to have higher quality for these services than hospitals or providers rather that are affiliated with the hospital. And so this could be something that does expand nationally, and similar levels of variation exist nationally. And this is kind of the start of reference-based pricing as a policy solution. Reference-based pricing has expanded from CalPERS to the states of both Montana and Oregon as a similar purchasing decision, as a way to recognize that the large degree of price variation faced by a purchaser isn't tied to quality outcomes or to other components of the hospital, and really reflective of market share. So the state of Oregon recognized that there was the similar range of prices. On the left-hand axis, this is the percent of Medicare, and then on the bottom is just each hospital ordered by the price across all sets of procedure. And what Oregon recognized that just like in Vermont, there are many hospitals that were under 200% Medicare and several hospitals that were above 300% Medicare. And so what the state of Oregon decided to do through the Public Employees and Teachers Health Plan was to cap prices at 200% of what Medicare pays. This program led to about a $50 million savings for the state of Oregon. And it's something that in ongoing work, we find no change in quality, no change in the financial viability of providers, and no change in provider staffing.
We have a question, Leslie?
That was my question. It was about the sustainability of the systems that were 300% that were then dropped to 200. So you're saying there was no impact on the sustainability of those organizations?
That's right. So the 20 or so hospitals in Oregon that this applied to, all 20 have remained in business, which is the most important thing. And if we look at hiring or staffing, whether it's physician, nurse staffing, we find no change in staffing. And I think and I should also say, we also don't find any number of procedures performed at the hospital. So for these hospitals, life has gone on as usual, even though they're making quite a bit less from the public employees. And I think one important thing to keep in mind for that is that, again, Medicare rates are roughly the break-even point for an efficient hospital. And so if you're getting that break-even point plus an additional 100%, that's still a very healthy margin, and something that's maybe the endowment doesn't grow as much, but in terms of keeping the core operations going, it's something that is still, again, a pretty healthy payment.
Can I ask
Of course.
question sort of about this, but also something you had mentioned earlier? The cost shift. The a hospital's ability to operate within the Medicare break even. And we know that some hospitals are far more efficient at doing that than others. And it looks like what happened here in Oregon is the hospitals that were running around 300% somehow were able to make decisions that did not impact care or providers. It sounds like they became more efficient.
Right. So whether it's becoming more efficient or they were already efficient, but essentially making a large profit, we can't tell. We can't distinguish between those two. But at least what we've seen in Oregon is that the core business operations of the hospital didn't change or have not changed following the implementation of the program.
I was just wondering if because I realized I didn't ask it. Do we find in hospitals that are less efficient at getting towards that break-even Medicare, do we find that there is more of a cost shift with those particular hospitals? I mean, I realize that, the concept that the cost shift isn't a real thing, but is it a real thing for, say, if a hospital is working around 70% of Medicare's reimbursement? In other words, if a hospital is far more efficient in getting closer to 100% of the break even and living within their means of that, is there less cost shift, but more for other hospitals?
Yeah, so I actually think that the cost shift actually might go the other way. So if we look nationally, and I think this also holds for Vermont, the hospitals with the lowest prices tend to be critical access hospitals, or critical access, or safety net hospitals rather. And that makes sense if you think that the way that a hospital is able to negotiate a high price with an insurer is essentially, you want a bunch of rich people who can buy that insurance product, insurers, health plan to be in that market. And so we actually see nationally that the most expensive hospitals are either the ones with huge and almost monopolistic market presence, or the ones that are appeal particularly to high income individuals. And so that kind of the way I think of hospitals, it's kind of the haves and the have-nots. And so the haves are appealing to high income individuals and able to reflect that appeal to negotiate higher rates, while as the have-nots and the safety net and similar providers are the ones who aren't able to have that negotiation presence and are thus underpaid, or paid lower rates by commercial insurers. And so we see that those hospitals tend to, whether it's operating more efficiently, because they're just more efficient, or just because they're more resource constrained, are the ones that tend to have a larger share of say Medicare or Medicaid patients.
We have a couple questions. Daisy?
This slide is really surprising and impressive. I'm curious if you have any data or can speak to the impact on public health. What was the impact from the patient's view?
Yes, so patients benefited from this because most patients in this scenario have either a deductible or copays or coinsurance that are tied to the price of a provider. And so if you're paying a deductible coinsurance at a provider price that's 350% of Medicare, and that goes down to 200% of Medicare, then that's a pretty large reduction in your cost sharing. And so in other work, we've actually seen that the use of services for patients actually increases.
Can you speak to, in this scenario in Oregon, I imagine that some of these hospitals had to change their service arrays and those be absorbed in the community. Do you have any scenarios as to how that impacted service availability to patients?
So if we look at the overall volume of procedures that a hospital does and differences in payer mix across the board, we actually don't find changes in overall procedure volume. And so presumably this, I think the case we would be concerned about is that a hospital decides, look, I'm just not going to, at 2% of Medicare, provide cardiac catheterization or some procedure, and so that's done in probably more likely to be like a primary care behavioral healthcare service, and that's not a scenario that we've actually seen play out in Oregon. So again, operations, whether it's patient care, staffing, seem to be relatively the same in Oregon before and after the implementation of the program.
Thank you.
Hopper has a question.
That's my question, is the impact on the patient.
And as I'm looking at this a little bit further, this was only, Oregon only did reference-based pricing for public employees and teachers. Did it have an effect on commercial prices paid, from small business, but everyone other than public employees and teachers?
That's a really good question. So you might be worried about essentially the squeeze the balloon effect, where a hospital, maybe they make less from the public employees and teachers, and so they have to charge everyone else more. And we've looked at that, and we find no change in costs for non-public employee prices.
Thank you. Oh, one more question.
So I apologize, I came in late, so you may have already discussed this, but I didn't see it in the presentation. So it was only for state employees and teachers, and I think you said it impacted about 20 hospitals. What type of hospitals? Were they critical access hospitals, rural hospitals, networks?
So Oregon excluded critical access hospitals from this program.
Great, thank you.
And so this is what we know from Oregon, and we can take what we've learned from Oregon, as well as what we see for existing prices, and apply that to the state of Vermont, and make some modeling assumptions. And we do that. We estimate that at 200% of Medicare, and applied not just to public employees and teachers, but actually applied to the entire commercial population, that would represent about a $400 million reduction in spending to individuals in Vermont. These savings apply to both patients who, as I said earlier, would have to pay less cost sharing, as well as for purchasers who pay the bulk of claims. And I think, as you can see here, we've looked at just the non-critical access hospitals and where these savings would apply, consistent with just having a larger market share and higher prices to begin with. The bulk of the savings are, depends on kind of what hat you're wearing. The bulk of the reduction in spending would apply to the University of Vermont, and we'd see smaller reductions for other providers. I think one other, sorry.
I'm sorry, is this modeling only state employees and teachers, or is it for the whole commercial system?
That's a good question. So for this, we've applied it just to so we've applied to the entire commercial population.
Okay. Thank you.
We were to do just public employees and teachers, the reduction in spending would be substantially less, just given that that's a portion of the population. The other, I think, important thing to keep in mind is that reference-based pricing and a move to a Medicare-based reference-based pricing model would likely substantially reduce administrative costs and simplify the contracting process. So if you're a hospital or provider, or negotiating a price with insurer, that's a pretty complicated and intensive negotiation. Essentially, you have to negotiate prices over every single set of procedures. But if there was a move towards a reference-based pricing model, then this is something where there'd potentially just be a single number that would be the focal point of negotiations, and that would simplify how you process claims, how you price claims, and how you design networks and contracts. And so that's something that, if we're concerned about administrative load within the healthcare system, might be something that would move towards more efficiencies.
I think we have another question.
For Vermont, do you see that there would be any benefit to doing a staggered approach and doing public employees first, and then move to the rest?
So I view that as a question more for So I view that as a question more for you than for me, to be honest. But in my opinion,
Do you have an opinion?
Doing this overnight might be something that would be a large shock to the delivery system. And so whether it's staggering in certain populations or phasing in at giving the existing rate and coming down a little bit each year, that might be one approach. And I think the other thing to keep in mind is that Medicare rates do increase year by year to account for just overall cost of inflation, cost of providing medical care. And so that would, paying to Medicare would still allow for those annual increases in cost of providing care. But I do think that, again, doing this overnight would be a large shock to the delivery system, and phased in either populations or the reference price would probably be appropriate. And I guess the other point I'd make is that we modeled this based on 200% of reference-based pricing, based on what we've seen from Oregon. I believe some existing Vermont policy proposals, but I'm not, I don't want to make a stand on whether that's the right price for reference price, if you will, for Vermont. I mean, maybe that 210 or 225, et cetera, is a more appropriate rate.
And we have another question from Leslie.
So I was just wondering, thank you very much, whether the Oregon has expanded beyond public employees and teachers.
That's a good question. I don't know if Oregon has, I believe there's been some interest among municipality employees, but I'm not sure if they've joined on. I know that other states that are considering similar types of models. So, for example, the state of Colorado is thinking about ways to either include the entirety of the commercial population, or to allow for not just state public employees, but also municipality, fire districts, et cetera, to be a part.
Thanks.
And then the last recommendation that I would make is that this is a reduction in spending to providers, and I think it's really important to make sure that these savings or these reductions rather are passed along to patients in the form of lower premiums and lower cost sharing, and actually not retained by insurers. And so,
Wait, one more question.
I'm sorry, on that last comment, one, would love to know, what other states, like what policies have been put in specific to that, and also how, thank you, you can make, how do I say this question? How you can really tie the two together versus what other factors are happening in the world at the time and in the state, that shows that correlation. And then my third question is, although this is only done in Oregon for the public employees, if it is it lowering premiums to other policyholders like small businesses or individuals?
Mm-hmm. So on the first question, I think that is, as you alluded to, a bit of a tricky question, just because there's lots going on, and there could be lots changing. I believe that Oregon did tie monitoring of the pass through. One, because it's a this applies to its self-funded public employee plan, and so they can directly see that they're getting the savings through reduction in prices. But if this were to be applied more broadly, I think using, say, rate review authority to guarantee that patients are benefiting and premiums are being lowered as a result would be important. And then I forget, what was your second question? I forget.
Yeah, sorry. My final question is, in the lowering of the premiums, is that across the board? So for instance, if you just put it on public employees, in the long run, would small businesses see the positive effect of having lower premiums?
So that, again, I think becomes a little bit complicated. So the public, if you're a self-funded employee plan, a reduction in your spending would apply just directly to your population. So you tend to benefit. But what we saw in the CalPERS experience is that Anthem and providers found it easier to not have a separate price for CalPERS and non-CalPERS Anthem enrollees for the same service and provider. And as a result of the reference-based pricing program that Anthem, or that CalPERS rather, put in place, prices across the board fell. And so actually about 75% of the overall price reductions went to non-CalPERS enrollees is kind of a spillover effect and spillover benefit to the broader California population. And so I think if there is downward pressure, then that's something that would benefit everyone.
Thanks.
And so just to wrap up, as I'm sure everyone's aware, there's just a huge concern about healthcare costs and the financial pressure that places on purchasers as well as individuals and patients. And I think as I highlighted earlier, just the huge variation in hospital prices, which are the primary driver of healthcare spending, is the glass half empty view, if you will, is that this is a huge challenge for the healthcare system and the delivery system. The glass half full view is that this is an opportunity to address price disparities and tie prices to value, and that's a potential opportunity to reduce spending and to save patients money and to reduce overall healthcare expenses. But in order to do this, I think we need transparency around pricing, and we need to have accessible price data to understand both what prices are, as well as what costs and expenditures, and essentially where how finances are being used. And I think the other just point I'd make is that we know that, as I highlighted earlier, that a large portion of price variation is driven by market competition and market concentration. And I think it's really important that there is a level playing field. So even in the absence of, say, a reference-based pricing model, which would, in my opinion, level some of that playing field, that there is equal footing for individuals in those markets not to pay high prices as a result of market concentration. So thank you, and happy to answer questions. And my email's here if there's any follow-ups, which I'd also be happy to answer.
Thank you so much. There was a ton of great information in there. Anyone on the committee have any questions? Daisy?
That was a fantastic presentation, and I apologize because my question is a bit of a side rail, but I have to ask it because I suspect you're one of the few people who might have an answer to this. Is anyone talking about the potential other reference points than Medicare, given the possible, or I guess, dysfunction that I anticipate we will see at CMS?
That's a good question. So I'll answer that in two ways. So one of the areas where there is straight Medicare pricing may not be directly applicable is, say, on critical access hospitals, which, as I said earlier, are paid on a unique cost plus essentially payment model. And so what some proposals have said is just to use the base Medicare price for those critical access hospitals, but maybe have a different reference price, if you will. So maybe not 200, but maybe 250 if you're a critical access hospital. The other area that I think this is really important, and is just I'm not sure directly how this applies to individual hospitals or in individual hospital in Vermont, but it applies to individual services in Vermont, is that while Medicare does have a price for say pediatric care, because there are individuals in the Medicare system who are, you get access to Medicare not just through being elderly, but through several different pathways. And so there are many under 65 individuals and even children who are covered by Medicare. But it is a bit of a question of how accurate or representative the non-elderly prices are for the Medicare system. And so in that case, many policy proposals, so for example, the state of Colorado for their pediatrics hospitals have used percent of Medicaid rather than Medicare. And then for the what's kind of going on DC question, my general view is that hasn't quite touched the core basis of how CMS sets Medicare prices. That's a pretty complicated process that's updated every year. I believe it's in statute, so it'd take a lot to change. But I suppose if CMS or the administration decides that we just want to throw Medicare pricing out the window, I frankly wouldn't know. I mean, I know what to do in that case.
Leslie, did you have a question?
I do, if I may.
Yes.
Thank you. You were talking about other possible benchmarks, I guess. What about the Medicare Economic Index? Would that be a possible measure to benchmark against?
And is that the index in terms of cost of providing services, wages, salaries, et cetera?
Because we have in our bill, and I'm just trying to understand it, it says, that we could use Medicare rates, but some alternative as the Medicare economic index measure of inflation. So I was just wondering.
Yeah.
Your thoughts about that. And then I have a
Yeah.
follow-up too.
Right. So that could also be used as well. So if, fix the kind of existing, payment rates, but as say cost of care or inflation increase over year, peg it to the Medicare expense index.
So that would be reasonable.
Yeah.
And this is my second question, it's a different topic. One of our section says the board shall identify factors that would necessitate terminating the use of reference-based pricing. So do you have any experience of needing to terminate that model?
I have not seen what that would be. And so yeah, I guess I wouldn't quite know how to look at that.
Thanks.
I have a question, but also on the side of our room is our healthcare advocate, and he's asked if he could ask a question, but I'm gonna ask mine first. And then Mike Fisher, our healthcare advocate, can ask a question. You were talking about market concentration, competition, but sort of, I mean, I think that one of the things that we hear about all the time is that we need more competition, that's one of the drivers of our high cost of care. Doesn't have anything to do with the things that we think it does. It's really about concentration of healthcare services or lack of competition in that. So how does a state the size of Vermont, with essentially one concentrated, I'm not even sure you could call it urban area, but not rural, and the rest of the state in a more rural, less densely populated, how do we achieve competition? I mean, we also only have one domiciled insurer, and only 2 insurers participate in our health exchange, our state health exchange. So how do we do that?
That's a good question. I grew up in the middle of Montana, and so thought a lot about these types of questions. And so I personally, as well as I think many other economists, are pretty skeptical of interfering with market functions, with the exception in cases where there is market dominance. And so market dominance can happen through you go out and acquire all the competition, and that's kind of the classic story. But it can also just happen through what's often referred to as natural monopolies. And so, that's just the case that, there's in some places, really only one, room for one provider. And that's, it's actually not efficient to have more than one provider in those types of markets. And so while maybe not intended to be or lead to concentration, the end result is we still get the same impacts of concentration. And so in those types of situations where you have a natural monopoly, it's I think often reasonable to have more of a heavy hand in terms of regulating prices. And so we see this often in utilities, where it doesn't make sense to have a house with 2 power lines coming in, and we get around that concentration problem, if you will, through this natural monopoly by having little stricter oversight into prices and performance.
Mike, do you want to
Sure.
introduce yourself?
Thank you, Mike Fisher, healthcare advocate. I want to just recognize that some of what you have told us today is a little counterintuitive. But just to sort of drive home the point when I ask the question, I don't know whether it makes sense to pull it back up, but your slide 6 that shows the variation in hospitals' commercial prices. One would logically think that a hospital that charged more is more likely to be economically stable. And when I look at this slide, and I don't know if you know this, but we have a number of hospitals that are been reported to be, I'll say, more vulnerable today, and they include Springfield almost all the way on the left. And then just to use the extreme on the right, Brattleboro Memorial Hospital is also stressed, and there's a smattering of ones in between. What sense do you make of that? That there, at least in the Vermont picture, whether you see this nationally, the commercial prices, at least in our example, don't appear to have a relationship to how many days cash on hand they have, how stable the hospital is.
That's I think a core question of how we think about hospital markets. And as I said earlier, I think of hospitals as largely the haves and the have-nots. And so if you are a hospital that say has a large uninsured or Medicaid base and just doesn't have the bargaining clout with commercial insurers, presumably that may include Springfield Hospital, then you just may not have the same financial footing as a hospital that does have that negotiation clout with a commercial insurer. I think the other important thing to recognize is that these are commercial prices. That is a portion of a hospital's business, and so that could extend as well. But then it's also important to recognize that the cost of running a hospital in many cases don't fall out of the sky, and some hospitals and organizations, whether it's a hospital or any type of industry, do tend to operate more efficiently than other settings. And so, without being too specific about individual Vermont hospitals, that's kind of a high answer, but I'm sure we could actually look at some of the individual correlates, if you will.
I'll just say the key word that I just heard you say was efficiency. Another. Yeah, thank you.
Thank you. Thank you so much. Gosh, it's a lot to think about. In the context of what we're seeing. So thank you for joining us. And we have Elena with
Thanks for
us.
having me.
Thank you.
Thanks for your work.
Hi, Elena. Good to see
Hello.
you.
Nice to see you all as well. Sorry I have to join via Zoom today.
That's okay. We're just glad you were able to join us.
Yes. Okay, so I will share my screen. Let me know if you can see it.
We do see it.
Okay, I'm gonna switch.
Very nice graphic.
Thank you. Okay. And so I'm happy to answer questions or use this time how you want it, but I've just put together some slides really focused on reference-based pricing, but really comparing it to other kinds of strategies. And for those of you that I haven't met, I'm Elena Barabee. I'm the former director of health systems finance at the board, but had gone back to Dartmouth to pursue my PhD. I'm still working part-time with the board, but not overseeing the hospital budget process like I used to. So I wanted to full disclaimer. And are you all ready to dive in or?
Yes, all set.
Okay. So I won't spend too much time here. I think you all know why we're talking about spending and prices. The US is, one of the kind of worst performing of its peer countries on healthcare spending for worst outcomes. Vermont, amongst all the states, is, consistently one of the highest spending states. A lot of this is due to a variety of drivers. We know we have greater administrative complexity, inefficient spending, resource allocation. So failures of care delivery. Sometimes we do things twice. We offer, low value care. We serve patients in higher cost settings. We'd like to see someone in primary care and can address their concerns there, but they may show up in the ED. And then we have operational waste. And I think what we've been talking about today, particularly with Dr. Whaley, has been these pricing failures that we've seen across the market. So there are numerous and multiple substantial kind of buckets where we can look to improve healthcare spending. So how does payment matter in this context? So first, I kind of want to start with some Finance 101. Just a reminder, many of you are familiar with this, but I think the last question kind of speaks to the two sides of the equation that we're dealing with. So hospitals, in order to stay afloat and avoid bankruptcy, keep the lights on, have to make some kind of profit margin or have to break even. So your revenues have to be sufficient to cover your costs. So your opportunity to, and then, some even for-profit hospitals and even non-for-profit hospitals really focus on that margin as a means to grow or a means to pay out their shareholders. We only have nonprofit hospitals in our state. So, this is really about growth. When your goal is to increase margin, you have two ways of thinking about doing that. You can increase your revenue, or you can decrease your costs. So I can either bring in more patients, more services if I'm paid per service. We'll talk about the different ways you can be paid, or you can work on spending less and to serve those patients. So there are three kind of core concepts, and please interrupt me, or if I'm going too fast, let me know. I have a tendency to get excited, but I'm happy to answer questions along the way. But there are three kind of core concepts that underpin how providers or how we pay for healthcare in this country and other countries. There are capacity-based models. So that is a payment to a provider organization to ensure future capacity for a range of services. So you may have heard of a facility-based payment. So regardless of who comes, we want you, and how many come, we want you to be open, and this should cover your fixed costs. And up to a marginal cost usually. And then activity-based payments really rely on the delivery of a unit of service. So this is where we talk about fee for service. You come in, you get a service, you paid an amount. You may have also heard folks talking about population-based payments. These are more rare on the facility level, but it's a model that pays an organization, typically an ACO or managed care organization, to care for a population. So this is regardless of the number of services that they offer. So to break this down a little further, in these capacity-based models, when you're paying for the availability of service, you usually set kind of a floor. So you want to cover your fixed costs. And then you could also use this to kind of limit excess growth. So it can kind of serve, a very small hospital, but could also serve kind of a growing, budding hospital to say, okay, we don't want to go over this amount. So you're going to have this, capitated payment, but it should cover, your facility. And so an example of these kinds of payments is really in the VA system. So they pay to keep hospitals open so that veterans can go use their services. An activity-based payment, as I mentioned before, encourages greater use of a unit of service. So when you're trying to increase your revenue, the more services you offer, the higher your revenue. And so you're really trying to maximize in your financial equation, at least, a higher margin or higher revenue services. So those services that cost less for you to deliver, but you don't want to be doing lots of services that you're losing money on. You want to do lots of services that you're making money on, because that will end up in a higher profit margin. And this is kind of the way that most provider facilities or most providers in the US are paid to date. And then population-based payments encourages greater use of more kind of low-cost care or preventative care versus acute care or lower-cost settings. I think there's this theory that if you paid providers on a population base, that would encourage a lower use of services. I think there's very limited kind of use. It's kind of a rare payment model because it really requires the provider to be a large integrated delivery system. And so you really only see this in places like Kaiser, where you have kind of control all over all aspects of healthcare delivery. Where you do see this is with ACOs and managed care organizations, as I mentioned before. So again, fee for service, this is kind of where the bulk of our revenue currently lives in the US. So Medicare sets fees based on the cost of production. So they set their prices based on what they think an efficient provider will cost to produce that service. And I think you've heard from a number of folks about this, so I won't go into the weeds on the methods or billing. Medicaid generally, as you know, varies state by state, but generally aligns with Medicare and pays, at or often slightly below Medicare. And then commercial payers rely on negotiating their prices. And so I think you heard from Chris Whaley, there's a lot of variation in how, whether and how providers are able to negotiate higher or lower prices. But their contract structures vary, and kind of the generosity of those payments may vary across contracts. And then I just wanted to call out, we often think about hospitals and we think about patient care, but they also, they also make revenue doing other things like offering, drugs, outpatient pharmacy. They may own a medical supply company, have investments. Some even are affiliated with venture capital firms. So there are different ways and other kind of strategic focus of hospitals that exist. So just want to remind folks of that.
Can I ask a question about that,
Sure.
Elena?
Yeah.
So, commercial payers negotiate prices. We talk about that all the time, contracting. But when you're in a state like Vermont and you have to have, say, network adequacy, is this really a contract, or is this just the illusion of a contract?
I think that's a great question. I think it comes back to what, how much bargaining power do you have? Can you credibly walk away from the contract? If the answer is no, then you don't have power in that negotiations. And negotiation works when both sides have kind of equal footing, right?
Yeah.
But when you have one player that can really set all the rules of the game, that's when you have monopoly power. And so that's why, we have regulation here. It may not be operating at this level of detail, but that is one reason why states have stepped in to kind of offer a more equal playing field across players.
So if you have that dynamic in your state where you have essentially monopoly type, because of your volume and your population and your size, and you have very few payers, few to almost none, isn't it inherent that really the only way that you can control prices is through regulation?
I would agree with that. I would say it would be very hard otherwise to control prices in a robust way. Yep.
Thank you.
Yep. Okay, so in a fee-for-service world, so you saw the equation before, the revenue is not just a function of price, but is also reliant on the number of services that are, or units of activity that are delivered. And so this is from a CMS actuarial report, and there's been a lot of evidence kind of in the literature since this report was issued, I believe, maybe a decade ago, but there is a correlation between price changes and volume changes. So what you see is when prices are reduced, in this scenario, you'll see increases in volume commensurate, so that the organization is trying to kind of capture, to stay whole, if you will. And so they're responding to changes in price. So now we're going to go to,
Just a question.
Sure.
Elena, sorry, you may not know this, but I would love to know if that means that some procedures may be being done that are not quite necessary. Does that drive that too? And I doubt you know that in your world, but if you could point me to some help, that would be great.
Yep, I can write that as a follow-up.
Thank you.
Okay. Wonderful. Okay, so on the other side of the spectrum, you have capitation. So that is kind of this capacity-based phenomena. It can also be population-based, but let's just talk about facility-based. So Medicare Advantage is one example of this. So Medicare pays a fixed price to private companies to manage care for the population. And then this private company manages a budget using plan design and provider contract negotiation. So the provider is still likely being paid on a fee-for-service basis, but the Medicare Advantage company, generally has incentives to build tools to, find efficiencies in terms of length of stay or lower cost providers in their network or redirecting care, to manage that budget. Kaiser, on the other hand, is a vertically integrated insurer and provider. So it's a bit different of a model, but they manage care for a population and the providers work together to manage the overall budget of care delivery. So this includes kind of costs focus. So in this scenario, your revenue is your capitated payment times the number of beneficiaries. So in this case, under capitated model, your revenue is now fixed. And so the focus is really on cost because you can't really change the revenue. So the way that you earn profit is really about being more efficient. But this can look different. So I think as you probably have been following the Medicare Advantage conversation, one way that unfortunate way that folks have managed this is through rationing of care, which means patients may not be getting care when they need it. I don't want to say rationing is a good thing. Sometimes patients get care when they don't need it, but it's really, really hard to tell the difference. Another way that you can address, cost management is about redesigning how you deliver care and where and how patients get care. And so this is, one example and one focus that you've often heard about is managing potentially avoidable emergency department visits. There's a lot of evidence that folks show up in the ED that could be better served at a higher level of quality in other settings. And so, those are kind of two ways, and it's hard to know which is happening without having another monitoring system or quality reporting system on top of the payment system. So I wanted to share that because I think, oftentimes we're looking for a silver bullet. If only we paid differently, all these things would happen. But I think, you need more than just payment to move to a higher quality, to make sure that you maintain a quality of care across your system. And so, there are inherent different financial incentives given different payment designs. So as we mentioned, this is just kind of summary of what I've already been talking about. So capitation kind of incentivizes lower costs, fewer services, or more lower cost services, whereas fee for service, it's more revenue given more services and higher margin or higher revenue services. And it's important to recognize too that, though I'm talking about these as kind of two options, there are many hybrid forms of payment that could be considered where you have perhaps like a facility-based payment with a variable component on top of it. So there are other ways that, you can kind of blend these concepts together. And I think the focus here on sections 2 and 3 is reference-based pricing. So this is one strategy, and I won't spend too much time here. I know that Professor Whaley he's our resident expert. But it could be, this is typically operationalized at the payer level, so like an insurer or an employer, and they set the maximum amount they're willing to pay. A regulator could also do this. So I think you've seen like Rhode Island, some other states have kind of these concepts where they have caps and which is still a reference-based price, maybe not the way that, it's been traditionally defined, but you could set a maximum or minimum a payer can pay or a provider can charge. So it depends, I think there's differing language in the bill, whether we're focused on insurance. I think you received some feedback. A better way perhaps to do this to capture more of the revenue would be to focus on the provider side, because then you'd really be applying the same set of rules, pricing rules to all commercial payers. So there's two kind of different ways you could implement this. And then I want to, I think this was another point of conversation, Medicare could be one reference point. So if you look at the bottom right chart, if you're, without reference-based pricing, your providers can negotiate a rate, and that starts really with their charge master, and then they negotiate those discounts. Versus having a reference-based price, you start with your referent, perhaps Medicare or Medicaid, and then you add your percentage bump. Another way to do this is to look at kind of the market and establish kind of a reasonable and customary price for a particular service. So, your referent here would be a market average, and you could define that, with some rational method. So I just want to kind of highlight there, while we've been talking about Medicare, there are other ways to think about creating reference. But I think the point is that everyone's kind of working from the same set of principles when determining that price, rather than relying on bargaining power negotiation, which can create huge disparities depending on how much power you have in a market. So I think there are benefits and challenges of implementing a reference-based pricing model. Some of the benefits are certainly cost containment, increased price transparency, supports competition. I think that you get a shift if everyone's working from the same kind of pricing structure. You're going to really look more at quality and efficiency in delivering against that price, rather than focusing your time and effort on getting more price out of the system. I think it could, if you're, seeking to reference-based pricing, encourage access, because I think particularly in areas where we have low volume and we want to see that grow, you can use reference-based pricing to do that. And it creates kind of a rational pricing mechanism again, instead of relying on kind of power-based pricing strategies. Some of the challenges, which I think you guys have already been thinking about, is balanced billing. There's also, potential for overutilization. So it's kind of on the other side of encouraging access. Are we seeing growth in the areas we want to see? So again, I think it's, we have to get the payment right, but I think we also need to remember that we need to monitor quality and outcomes of care and what services people are getting access to. So this kind of compares reference-based pricing and global or capitated payments and when each might be helpful. So I think, if you want to increase competition, reference-based pricing is a great way to do that. Global capitated payments usually work best for regionally dominant integrated delivery systems. And so they kind of give preference to those who can control the whole system, where reference-based pricing allows a more decentralized competitive structure. Again, reference-based pricing might be good when you need to increase or incentivize greater access or volume, whereas a global or capitated payment may be more appropriate when you want to limit capacity or kind of curtail volume. And then I think, price efficiency payments are established based on efficient delivery of a particular service. This would presume that your method is based on efficient delivery. And so I think it's whether it's efficient delivery of a particular service or efficient delivery for a set of services, kind of the focus may be a little bit different when developing that payment.
Oh, Elena, back on that and the competition aspect of it. So this bill, S-126, it sort of has reference-based pricing and then global budgets also. And, I'm sitting thinking, how do we weave this together as far as like a timeline?
Sure.
But can you just say a little bit more about reference-based pricing and global in the types of markets that they're better suited for?
Yes. So I think reference-based pricing, because it has the incentive to produce more volume, it may be more appropriate when you have underutilization or gaps in access to care, right? Because you can use reference-based pricing and you need that volume incentive. I think a global or capitated payment, and I want to differentiate that. I think the bill has budget, and I'm a little confused whether it means a budget, which I think we're kind of doing, or we've been doing historically through establishing a NPR or net patient revenue cap in the hospital budget process. But if it actually means global payment, that would kind of replace the reference-based pricing approach. So that is a question for intent, is whether that's really supposed to be a payment or if it's really about establishing a budget cap, because those are they're two different things. But I think that, if you're trying to cap a system and you're capping a budget and volume, you're going to see reduced number of services, or a recalibration of which services, depending on who owns, like how much of the system you own. So like I said, so if you're in a delivery system where you own primary care, emergency department, and specialty care, and you have everything, you may be a global or capitated payment may incentivize you to shift people to lower cost departments, right? But if you only have primary care, for example, reference-based pricing might be good if you want to increase the number of patients seen, right?
Great, thank you.
Great. So this is just kind of in summary, every system is perfectly designed to get the results it gets. So I think there's a lot of questions. I don't think there's just one simple solution to these very challenging topics, but I think, perhaps thinking about where fee-for-service and capitation make the most sense, or when or for whom may be important. We have to think about how the whole system works together and how all the incentives interact. So which services should be paid in which way and how much, how to make sure that payment encourages the kind of utilization we want to see or discourage the kind of utilization we don't want to see, and how do we know if access is improving or not? Are people getting the care that they need when they need it, in order to avoid having, more costly care down the line? And so I think we have to start somewhere. I don't mean to be overwhelming by posing all these questions, but I think this is going to take time to get it right. And we kind of want to start small and scale. But I think it's a really important topic, and I'm very happy to see so much discussion about advancing our payment reform in the state. So I will stop there and see if you all have any
Thank
questions.
you. We have Leslie has a question.
Thank you, Elena. So when we see a lot of data about reference-based pricing, it's usually about a procedure, MRI, colonoscopy, whatever. Are you imagining that could apply also in primary care, or is it not?
I think primary care, and I have to pull up the report, the National Academies of Medicine issued a report a number of years ago that really advocated for a hybrid approach. So I think you heard from some providers that it's great that we get paid when patients come to visit us, and that creates a volume incentive, but we also do all of this work outside of patient visits that's not directly reimbursable. So I think it is important to have a mechanism where people are incentivized to use their time efficiently, but also comprehensively. So there may be kind of a hybrid approach that would be warranted in that case.
Yeah, if you could send Kristen the reference, that'd be great.
Yep.
If you still, you said it's kind of old, but maybe it's still relevant.
Oh, it's very relevant. It's still kind of the North Star for much of the work in that space. Yeah.
That's great. Thank you.
Any other questions for Elena? This has been great information. So, and looking forward to seeing you again tomorrow.
Oh,
Cool. Yeah.
Great. Well, thank you for having me.
So thank you. I think we're going to take a break. Let's take a 15-minute break. And Dr. Fisher has agreed that he can scooch back a little bit, so that's good. We will come back here